Welcome everyone. I'm Andrea Baccarelli. I'm the Dean of the Harvard T.H. Chan School of Public Health. And this is my distinguished pleasure today to welcome Dean Nir Menachemi, who is the Dean of the Fairbanks School of Public Health at Indiana University. Thank you for being with us today.
My pleasure.
Nir's work in science focuses on health economics and health systems organization. And you will hear a lot of that as well. But the reason why we invited him today is for one of his major interests, which is to communicate public health and to forge alliances with any stakeholders, and especially policymakers. During his career, Nir has been incredible at creating partnerships, alliances, and collaborations and communication with state and local government officials in Florida, Alabama, and now in Indiana. He has built excellent relationships with politicians from both the Republican and the Democratic parties, and most important, has forged bipartisan coalitions that have substantially advanced public health. So we are here to find out what is the secret recipe, how you have done that. So let's start with the questions.
Sure.
My first question is, how did you do it? Talk me through some of the core principles of effective communication across the aisle.
Yeah, thank you, and thank you for the invitation to be here. I've really enjoyed getting to know folks so far and look forward to more conversation. You know, yes, this is a very timely conversation, and yes, this is about communicating across the aisle, but almost everything I'm going to say is about being an effective communicator, whether it's across the aisle, whether it's with, members of an opposing team, like in sports teams, whether it's, your neighbor, your friend. At the core of it, communication is about exchanging ideas and trying to get a deeper understanding of someone else and to convey an understanding that you have to someone else. And you probably learned this in kindergarten. One of the ways to effectively communicate is to not be offensive. And when we put it in the political or the partisan even perspective, we use language that really is rooted in values that we might have and is frequently, maybe even unwittingly, being characterized from narratives that we subscribe to. And so every single one of us has certain values that bring us to a discussion. And we also don't realize this, but we all have narratives. And what is a narrative? It is a story, and I don't want to suggest that a story isn't true, but a narrative is a story that tries to make sense of a very complex world around us. And so let me just give a few examples of values versus narratives, because I want to kind of weave that into the story here. But, from a political perspective, some people might value civil rights or social equity, maybe environmental justice. Another set of values might be personal responsibility or individual freedom or limited government. Separately, narratives are, like I mentioned, stories that help us make sense of the world. And it's important to mention that when we have a narrative, we believe it to be true by definition. It's not something we choose or, we subscribe to this idea and we do because we believe it's true. So let me give an example of two maybe opposing narratives so you get a sense of how it's different than values. So here's one. Immigration strengthens our country by bringing diverse perspectives and talents. Another narrative might be that illegal immigration undermines the rule of law and puts strain on our limited resources. And so both of these narratives are rooted in different value sets. And so if you want to talk to someone, you cannot trigger a defensive posture because you are stepping on a value or disagreeing openly with a narrative. And so when you think about how we in public health have historically been thinking about the healthcare system, we very frequently take a negative and historical orientation. We talk about what's wrong with the system. We outline all of these different things that are frankly enraging about what's wrong. And it's very frequently tripping up on both narratives and perhaps values that people who have a different perspective might subscribe to. And so one of the things that you have to think about, especially in the context of public health, is rather than being negative and historical, why not talk futuristic and positive? And we've been pretty successful in thinking about things. So let me give a tangible example. Rather than say that there's, systemic racism in the healthcare system that causes disparities and we must correct it, that's very negative and historical. You could say, shouldn't everyone have a shot at the American dream by having a healthy life? It's the same message, but designed not to trigger someone's values or narratives in a conversation. The main goal is to bring people in to have an exchange of ideas. Without that, there's just going to be arguing and maybe even fighting and getting angry.
Thank you so much. Building on that, how do you handle communication on issues where there is a lot of disinformation or misinformation or even willful distortion of the science, such as, for instance, to pick one example among many, vaccines?
Yeah, I'll talk a little bit about my experience with this. We've been very active working in the area of both vaccines and during the pandemic. But let me just say this, and we got to own this. Public health is not known for being good marketers. Almost always the message has like a nagging undertone to it, right? Don't drink, don't smoke, don't have unprotected sex, don't forget, wash your hands, floss your teeth, no salt, no sugar, no fat, no smiling, don't have a good time, don't even laugh.
Guilty as charged.
Yes. So as I think a discipline, we have not been particularly effective in information. I think we've been right a lot, but that doesn't mean we've been effective. When I think about misinformation or disinformation, the misinformation part I think about as driven by ignorance. Someone is misinforming, someone is spreading information that is not correct, but isn't necessarily maliciously intended. I think of disinformation as having malice associated with a nefarious intention. I think disinformation is on the rise, but is actually a smaller problem, but a more serious problem than misinformation. When I think about misinformation, I think about it as resistance to truth. And I think about sort of like from a leadership perspective, what we know about change management and why anyone would, resist change. And I think there's correlates there. If you think about change management, there's only 3 real reasons that we have documented in the literature that people resist change. And it's, I don't understand it, I don't like it, or I don't like you, the messenger. And I think misinformation is usually fueled by one of those things too, right? I don't know what the truth is, and I think there's another viewpoint that I want to get out there, right? That's unwittingly misinforming. If you misdiagnose the reason, again, I don't understand it, I don't like it, I don't like you, we're going to spend a lot of energy that's going to be ineffective. And so frequently, if it's I don't understand it or I don't like it, we got to get quickly to the bottom of it. Mm-hmm. Because of kind of the polarized environment that we're in, I think the I don't like you, the messenger, we see happening in real time. When President Biden would have something to say, people on the opposing side automatically disagreed because of who the messenger was. In other circles, when President Trump says something, automatically a group of the population disagrees. And so we have to figure out what is causing the misinformation and then deal with it. And you'll deal with it differently depending on the cause.
Following up on that, so given this situation, how do you deal with people who might be reluctant to change their minds about public health?
Yeah, so my experience tells me that if they legitimately understand what public health is, rarely do they resist it. I have not met a lot of people who understand the principles of prevention and societal changes to allow for health to occur and to prevent disease and injury and prevent the progression of disease and injury. I think there's a lot of misinformation about what public health even is. And I think the average person, and this is actually based on some of the work that we did in Indiana, especially the average policymaker, does not differentiate between clinical care and public health as a science and as a set of societal tactics for preserving and improving health. And so, many times they think that prevention is clinical preventive services, maybe vaccines, maybe mammograms or, colonoscopies, but they miss the bigger picture. Others think public health is just, healthcare access for low-income Americans. All of which is inclusive of public health, but none of which is really what public health is about as a philosophy. And so we have to reach people who don't understand what it means. And the only way that I think we can reach people, and again, this is outside of a partisan or a bipartisan framework, it's you got to connect with humans. And we talked a little bit about this at the lunch today, but at the foundation of every human relationship, to individuals, to organizations, to nations, is trust. And I put this in the context that I like to think about sometimes. We think the pandemic is over, but we're actually in the midst of a much larger and potentially more damaging pandemic that is affecting virtually every member of our species on the planet. And I refer to it as a vitamin T deficiency, where T is trust. And when you don't have trust, you cannot have human relations at any of the levels that I described. And so when someone just won't change their mind, and it's important to change their mind, you have to develop a human-to-human relationship so that you can build up trust and be able to get to the point where discourse occurs. Now, if someone just still won't change their mind, move on. There's better things to do.
So, thank you for referring to your experience. I would like to hear, would like all of us to hear more about it. Particularly your work in Indiana. In 2023, the Indiana legislature passed a huge increase in public health support. Previously, the state has sent $7 million a year to local health departments. The new law committed $225 million over 2 years. And it passed with overwhelming bipartisan support, I understand. Can you walk us through the process of building this coalition?
Yeah, thank you. And so if you don't mind, let me just put a little bit more context there. That was a 1,500% increase in public health spending. We are a very conservative and business-friendly state. We have a very conservative legislator, and we have a conservative governor. And so to be able to increase public health spending at the time when trust in government, trust in science, and trust in public health has potentially been the lowest it has been in generations, it was pretty remarkable. And it was a multi-step process, and our Fairbanks School of Public Health played a role in helping to catalyze the discussion and then support it. But it's really the work of our state health department and elected leaders, and I'll kind of walk you through the story. So it was the end of 2020. A local foundation in Indianapolis called the Richard M. Fairbanks Foundation, same namesake as our School of Public Health, commissioned a report among some faculty in my school to do a critical examination of the public health infrastructure in Indiana. And the report did a couple of things. but among them identified how Indiana does relative to neighboring states. We're right in the Midwest, but also relative to comparator states. And those were states that we selected based on similar demographics, similar political leanings. Almost always in Indiana and other places, states are compared to exemplar states. And that's not a fair apples to apples comparison. You just have a different set of circumstances there. But we compared us to the US overall, to other local states, and then a fair comparator group of states. And just like we anticipated, it showed that Indiana was behind, both with public health investments, in terms of outcomes, disease outcomes and mortality. We were significantly worse than the US average, and frequently lagging the comparator and neighboring states. But more importantly, there was a massive amount of variation, all of which was very poor, across counties in terms of how often public health services were available. I'm talking about environmental health services, emergency preparedness, maternal child health kinds of stuff, bread and butter public health services that just weren't available to a lot of our state residents. And an important thing that we found is that Indiana overly relies on local dollars to fund local public health. That's property taxes, that's local sales taxes, and that's in contrast to US norms, where state level funds a lot of local. And so we basically made some recommendations. We talked to a lot of stakeholders. We got a lot of input in this report, and we put out this report and said, we'd really like it for the governor to appoint a group to look at this and maybe consider whether or not some of these recommendations can be put into place. And the governor, Governor Holcomb at the time, we have a new governor today, appointed the Governor's Public Health Commission and empowered it to really in earnest look at the recommendations and to crisscross the state and to talk to folks and do what I call public health 101 stuff, right? Coalition building, inter or cross-sectoral, coalitions, talking to folks, both elected officials, business owners, community members. There was a listening tour that the commission, and we had representation on this commission from the Fairbanks School. All of this was supported by the State Department of Health, and the commission went around and had grassroots conversations with folks. Some of it was, here's what we're trying to accomplish, here's what we know. The report that we published became the new narrative that everyone shared in common, which created a catapult into getting into issues. This is where we had identified that not a lot of people know what public health is. And so we had to spend some time helping to educate folks. And the example that I like to give is we would talk about how it's more about playgrounds than about, Medicaid. And the example we would give is you have kids getting injured playing on the playground. And you can either make them not be kids and not want to play and climb, or you can take all the tires from the side of the road that are an eyesore, shred them up, and let's bring some of these playgrounds up to code, and thus prevent, injuries. We talked about how, wearing helmets or even having car seats available. All these things are equally public health as any of these other things that are not really capturing what public health is about. And it resonated. It resonated because in a conservative state, a lot of folks have values that are about personal responsibility, about not being told what to do, but wanting to be empowered to do the right thing. And the message began to spread. And so the commission was transparent and allowed for, public comments and put everything on the website and allowed for the exchange of information. Every time they went from one part of the state to the other, purposefully invited elected officials, business owners, come and talk to us. Here's what we're trying to accomplish. You might have better ideas on how to do it in your community. We certainly can't prescribe it from the national level or from the state level. And much to the governor's credit, he chose two co-chairs that in retrospect were brilliant. One of them was a extremely well-known elected official from the Indiana Senate. He was a former senator from the state, who was really known to be very fiscally conservative and frankly a skeptic of government dollars invested. The other co-chair was a national leader in public health, Dr. Judy Monroe, who's over at the CDC Foundation as its president, but she was also a former state health commissioner in the state of Indiana and was trusted and was known. And so having a political expert and a public health expert kind of marry their expertise to figure out how to get things done allowed us to bypass many of the challenges that were experienced along the way. But if I had to summarize, it was good old-fashioned, go out in the community, talk to people, understand their concerns, reformat how you're thinking about things, and most importantly, doing what I said when we first started, being future-oriented and very positive-oriented as opposed to historical and negative. And that attracted people to the conversation.
And can I ask you in this process, what were the biggest hurdles you or the team, the coalition experienced?
Yeah, so we found out that a lot of people just don't understand, right? You could say it again. Right before all of this was happening, the city of Indianapolis, which is the biggest city in the state, also the state capital coincidentally, was an applicant for the Amazon headquarters too. And we are a very business-friendly state. We love attracting new businesses. This was going to create jobs. And we made the top 20. We didn't make it to the top 10. And the feedback we got was population's not healthy and the healthcare costs are expensive. And anyone who's in public health basically says, well, yeah, of course, like there's a relationship between health and wealth, but it's absolutely not intuited by people outside of public health. And so in our report and then throughout the work of the commission, we made sure to tie the concept of population health to the economic prosperity goals of the state, and invariably reframe public health's goals also as supporting businesses. So frequently we would look at populations between 25 and 64, which are prime working age years, be able to describe, for example, how behavioral health issues was really hollowing out this population group across all race categories, across geographies of the state. That got businesses' attention who are struggling with finding healthy folks that can work. And so we started finding ways to change the narrative to align it, not challenge it, but to integrate it with public health. But some of the challenges, remember, this was 2002, 2003, people were upset about what was going on after the pandemic, and that people had perceptions that public health overreached with whether masks or vaccine mandates. You had to take it. You had to listen. You had to build the trust. You had to allow for that information to be shared. There was also some issues, and I think we overcame it with this perception in some of the smaller rural counties that this is just the state trying to control the locals. And we had to have compromise. And so in Indiana, we have potholes is a big thing. And so road quality is an issue that we experience at the local level. And a bunch of years back, there was a deal that was struck, including with the leadership of that co-chair, that was Senator Luke Kenley, where they found a way to make the state not control the locals in the context of fixing potholes. And so money would be allocated, states had to have a 20% stake, and got to decide how it was going to be done. It wasn't going to be a contractor from the state level. And so a similar model for the new public health dollars was adopted, where the counties could decide how to use their money however they saw fit. Some might make part-time employees full-time, others might outsource couple counties might get together and hire an epidemiologist with their money. Some of them might work with, organizations in their community or otherwise. And after the first year, there would have to be a 20%, match from the county level. But importantly, the county got to choose whether or not they opted in or out. And so this was some of the, I think, genius of the co-chair, who had the political insights on understanding how to navigate the complexities of some of these narratives and values that people share, depending on where they're from. And so at the end of the day, a lot of compromises. Another compromise was that I think it was 60% of the dollars flown to counties had to be focused on prevention. No more than 10% on capital improvements or vehicles or stuff like that. But if you're not having the discourse, you don't know what people are not happy with. Mm-hmm. And if you remember, I talked about resistance. I don't understand it, mm-hmm. I don't like it, or I don't like you, and we overcame all of those. I don't understand it. That's what the report that the Fairbanks school did. Helped create a baseline information. I don't like it. That's where trust and conversation and transparency and discourse happens so that we can understand. And luckily, the co-chairs and the governor were trusted, and it wasn't a messenger. And so we aligned everything up, and pretty proud of what happened.
So now this was in 2023. Now we are 2025, 18 months later. And how's the climate now in Indiana related to this public health investment?
Yeah, so we have a new governor. We had bipartisan support, even though most things in Indiana do not require bipartisan support to pass. But more importantly, we had grassroots support. I mean, when you have business owners and, local council elected officials saying, oh yeah, we need to do this. Mm-hmm. This doesn't wane back and forth, based on one administration to the other. So the good news is the new Governor Braun, our new governor, reappointed the state health commissioner, Dr. Lindsay Weaver, who played a big role in helping to implement what we call the initiative Health First Indiana. So that was a positive signal. I think he has been very positive towards public health, but we're a little bit in a financial situation at the state. And so while I am confident there's going to be support, I don't yet know whether or not, there'll be some cuts to that $220 million. At least the first, proposal dropped that down by about $50 million, which would still be a massive increase compared to baseline. So cautiously optimistic, but right now in the current fiscal environment, every state agency is looking to take a cut, but I think this one has the potential to do well because of how much support it has and the realization that, and this was a Benjamin Franklin quote, an ounce of prevention is worth a pound of cure. I think by even invoking founding fathers and being able to talk about public health, it's a way to be historic without being negative and demonstrating on how American some of these, concepts are. None of these things are in conflict with who we are as a people.
Thank you. That's really amazing. Now, I would like to bring it to the universities. So how do we get everyone in this room or everyone in this building or everyone in America who is a student of public health to be an effective communicator and to be an effective leader so everyone can help move the needle?
Yeah, so I love being in public health because as a discipline, we attract an extremely talented and way above average passionate subgroup of society. People who come to public health feel like it's a calling. Mm-hmm. It's rare that anyone is in public health and is not excited about the work. And that maybe contrasts to some other disciplines that have both intrinsic and extrinsic, rewards. I think a lot of folks are here because it's aligned with who they are and it's the right thing to do as they see it. You mentioned the word leadership, right? And you think about what leadership is. It's about getting people to do things that you'd like them to do, right? And Simon Sinek is a leadership guru who I really enjoy his work. He says leadership is a choice, not a rank. Every single person can exercise leadership. But I think the passion of the folks in public health isn't usually or ever really tempered with some of the skills to be effective leaders, right? It's really easy to get people to do things when they already think like you.
Of course.
Right? I have convinced a couple of folks to shave their head, but they were already bald and using a different, technique than the one I was arguing. It's a lot harder for me to convince someone who doesn't shave their head to do so on a regular basis. And so I think we got to equip public health students with the tools and the skills to work with people who are not like them. And it's almost the opposite, right? The default way we think about things is when someone disagrees, and this is not in public health, but in society, when we disagree, we want to go to proverbial war, right? We use bellicose language like rally the troops and let's go let that other side have it. And that's a one-way ticket to have nothing happen, or worse, have good energy annihilate bad energy and go nowhere. And so how do we take, for example, some of the lessons from Indiana, but lots of other states and lots of other people have been talking about this, and finding common ground, not needing to accomplish everything and focusing on what we can do together, as opposed to what we would like to do that's different than, for example, what someone else would like to do. And I could give some examples of that, but I would love to see more of that work. And frankly, and I say this all the time, when I interact with elected officials and even community members, I never use words that signal what my political affiliation is. If someone wants to talk about that, I'm happy to, but generally speaking, as a public health expert, I don't see my role as taking a partisan side. I see my role as advancing the public health mission. And as soon as I create a us versus they with any listener, with any group, with any individual, I am basically shooting myself in the leg from being able to, create anything with this person that both of us can be excited about. And so that skill set, I think, fits with the leadership, trainings on how to get people not like you to follow.
So, thank you so much. As we wrap up, any final advice for public health students?
Yeah, this is frankly a really exciting time to be in public health. A lot of people that I speak with think that this is a challenging time. I think it is, but it's a challenging time for a lot of folks in a lot of disciplines. I think now more than ever, the public health mission is more important than ever. I think the constituencies, the communities, the people that we represent not only need the field of public health, but really are comforted by the ideas that public health represent. I think the challenge on us is to deliver the message, to be the partner, and partnership requires bi-directional learning. I'll mention that I was born and raised in New York City, but as an adult, I've lived in lots of different states, including Maryland, Florida, Alabama, and Indiana. And my understanding on what it means to be an American has evolved and in fact strengthened, having lived in different areas, walked in the community shoes of different communities, understood local issues. I mean, this sounds silly, but I grew up in New York City. I didn't know that good morning was a greeting for strangers. In Alabama, not saying good morning is rude. In New York, at least when I grew up in the city, saying good morning was intrusive, right? And having an appreciation for how lived experience is different is a key to understanding how to connect with people, which then allows these conversations to happen. But you can't ever think that you are the sage on the stage, that you will have the message that they need to hear. You have to be open to learning. And I think then the magic that public health does can happen.
So this is fantastic, and this brings an end to the formal presentation of the day, and also we are going to say goodbye to our online audience now. Thank you for joining us, and those of you who are online, have a wonderful afternoon.